Coming to cirrhosis, if there is recurrent episodes of parenchymal inflammation and necrosis and that becomes chronic, finally the liver lands into your cirrhosis. In that, there will be fibrosis, of course, because of chronicity and regenerative nodules. And also there will be blood flow disruption, your portal resistance, which leads to your portal hypertension. Okay. And also systemic manifestations that might be your CVS manifestations, renal, pulmonary, CNS, and also hematological manifestations. Let's see one by one later. So what are the common causes of your cirrhosis are chronic alcohol abuse and non-alcoholic steatohepatitis. These are your major causes. Other etiologies might be biliary inflammation, that to chronic or chronic biliary obstruction, anything chronic active hepatitis, chronic right heart failure, autoimmune hepatitis, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and certain drugs or toxins if there is prolonged and chronic exposure to those toxins. Coming to manifestations one by one. Firstly, hematological manifestation. To maintain the normal hemostasis in the body, there should be synchronization between three things. Okay, coagulation, anticoagulation or fibrinolysis, and your platelets. Okay. Unfortunately, or fortunately, liver helps in the maintaining of all those three things. So if something happens to liver, all the three things get disrupted. Okay. So let us see one by one. First, the coagulation factors. Liver synthesizes all your procoagulant factors and also anticoagulant factors except 3, 4 and 8. Please remember 3, 4 and 8 are not synthesized by your liver. And liver helps in synthesis and also it clears the activated factors. So, decrease levels of your anticoagulant factors because liver helps in the synthesis of anticoagulant factors too, right? So, decrease in those anticoagulant factors balances the decrease in procoagulant factors up to some extent. So, there might not be any bleeding manifestations up to some stage because thrombin generation is not that altered. So your conventional coagulation tests like TT, APTT might not give accurate results about the bleeding state. So we have to go for your TEG or ROTA. And also there won't be any protection against your VTE. So we can't tell whether bleeding occurs or not, whether there will be thromboembolism or not. So all that is we have to know regarding that in your real-time TEG or ROTA. Suppose cholestatic disease, prolonged cholestatic disease is your cause for your cirrhosis. In the starting stages, what is the problem in cholestasis diseases? There will be functional deficiency in vitamin K dependent clotting factors because vitamin K is not being absorbed. Due to obstruction, there will be no bile salts, there will be no vitamin K absorption, but not, there is no problem in production of those clotting factors. The pro-factors are being produced, but vitamin K is not being absorbed. In those conditions, in the starting stages of cholestatic jaundice or cholestatic diseases which are leading to cirrhosis, vitamin K can help in this clotting deficiency. So, vitamin K will be given 10 mg IM or IV for 3 days. Because here vitamin K is helpful as long as your liver function is normal. Here the problem is your cholestasis. The problem is with the absorption of vitamin K, right? So, vitamin K can help. But if the problem is with the liver, if the liver got affected and this profactors are not being produced, giving vitamin K might not be of much use. So, this is about the effect of liver on the clotting factors or anticoagulant factors. Coming to platelets. What is the normal function of platelets? It has to help in primary hemostasis by forming a platelet plaque, right? If the liver is normal, the thrombopoietin production will be normal and the platelets will be normal. If there is problem with the liver, this thrombopoietin decreases leading to thrombocytopenia. Apart from decreased thrombopoietin, the other causes of thrombocytopenia may be your sphenic sequestration, immunological mechanisms, or direct bone marrow suppression. But previously we saw that decrease in clotting factors is being balanced by decrease in anticoagulant factors. Here, decrease in platelets is being balanced by increase of your von Willebrand factor. Up to some extent, this increased levels of von Willebrand factors will compensate for this decrease in platelet, causing reasonable amount of platelet endothelial cell interaction and so helps in the formation of your phlegm. The second function of platelet being promoting thrombin generation and thus you're helping in your coagulation. The minimum platelets necessary for this to happen is nearly 56,000. So, platelet transfusion we'll be doing based on bleeding manifestation, not just by the counts. Okay. The third thing is your fibrinogen levels and fibrinolysis. Okay. Uh, to some extent, your fibrinogen levels might be normal, but it will be defective functionally. There will be qualitative defect in the start. There will be qualitative defect if the quantity is normal. And also, if we go for fibrinolysis, what happens normally is the plasminogen is converted into plasmin by tissue plasminogen activator. This formed plasmin helps in the consumption of fibrin. That means it degrades fibrin, causing fibrin degradation products and your D dimers. This liver is a site of this TPA clearance. That means it helps in the clearance of your tissue plasminogen activator and also synthesizes plasmin inhibitors. So it has to clear both. It clears TPA and it produces plasmin inhibitors. What happens in liver deficiency or liver cirrhosis? The TPA clearance gets affected. That means TPA is increased. So this process gets increased, more plasmin. Okay. Again, the liver helps in the synthesis of plasmin inhibitors, right? Again, liver deficiency, liver cirrhosis. This synthesis of plasmin inhibitors is decreased. So again, there will be increase in plasmin. All this causes increased fibrinolysis. So to assess the actual state, actual severity of this fibrinolysis, we have to go with TEC or euglobin clot lysis time. So in TEC, we'll be seeing clot lysis index. It is nothing but clot amplitude at 60 minutes and the maximum clot amplitude. The ratio, if it is less than 0.85, it means there is fibrinolysis. So we have to treat it with antifibrinolytics like your tranexamic acid. Coming to there will be thrombotic diastasis followed by widespread secondary fibrinolysis. We have seen that. And it is a bleeding diathesis of both factor and platelet deficiency. But this is seen after decompensated state of your CLD. This accelerated intravascular coagulation and fibrinolysis, please remember, is seen in severe decompensated disease. Like if there is adding factors like your sepsis or spontaneous bacterial peritonitis, finally it will progress into your DIC. We might see anemia also because liver helps in the formation of red blood cells. There will be in liver cirrhosis, there will be destruction of red blood cells, bone marrow suppression, and also nutritional deficiency. And of course, there will be splenomegaly, which is congestive type due to portal secondary to your portal hypertension. So there will be thrombocytopenia and also leukopenia. So till now we have seen that there will be problem in the hemostasis. Okay, that depends on whether coagulant factors are affected or anticoagulant factors are affected, how much the platelets are affected, to what extent is the fibrinolysis and all. So deciding on blood transfusion should be very much cautious, because if we go on giving blood transfusion, there will be increased nitrogen overload and there will be encephalopathy also. But before any procedure, we have to take care that coagulopathy is corrected. So we should be doing all the transfusions in a cautious manner.